Today I'm going to talk about steroids in wheeze, and in line with the theme of science and stories, I'm going to sort of weave you a little bit of a story about a study that we undertook at what was Princess Margaret Hospital, now Perth Children's Hospital, a study that is known as PREVIEW. Like all good researchers, we have an acronym for our research. The acronym for PREVIEW is Prednisolone Response Evaluation in Viral-Induced Wheeze. And this is particularly a study that has been undertaken in preschool children, just so that it sets the scene of what group of children we're looking at. So let's give you a little bit of a story. So we've got a 3-year-old, Jimmy. He's come into the emergency department. It's the third time he's come in. He's got wheeze. He's had a cold with a runny nose for the last 2 days. He's got moderately increased work of breathing. His respiratory rate's 36 a minute. He's speaking in 2 or 3 word sentences, but there's mildly reduced air entry at his bases, and he's got an end expiratory wheeze when you listen with your stethoscope. So the first thing that we need to decide is how severe is this wheezy episode that we're dealing with. Quite often we don't actually determine this in a sort of organised fashion. So our hospital has a system to actually score wheeze when children come in. It's a simple score, it's known as the pulmonary score, and it evaluates 3 variables: respiratory rate, the amount of wheezing, and the amount of accessory muscle use. And in Jimmy, he has a pulmonary score of 4, which puts him into our category of a moderate wheezer. So the dilemma: what do we do? How do we manage Jimmy? He's 3. He's got wheeze. Well, it's not really very complicated. Most people in the audience would be using a beta agonist administered via a spacer, small spacer, with a mask, and would give him burst therapy. So 6 puffs, 20-minute leave for the first hour, and then assess response and determine how quickly you can actually space him out. So that's not really controversial. Let's look at some of the controversies with these sort of types of children. Going back to the Australian guidelines, which actually helps to sort of give us the benefit of lots and lots of experts who get together and look at all the evidence. And when they're talking about children who wheeze, who are between 0 and 5, they actually say, well, episodic respiratory symptoms are actually incredibly common in children, particularly those under 3 years of age. Okay, that's good. But you can't actually do objective lung testing very easily, and it's basically not a feasible thing in this age group. And a high proportion of these children do not go on to develop asthma, even though they've responded to bronchodilator in that episode of wheeze under 5. So we don't really know what we're dealing with. We've got this group of children who wheeze in childhood. The first group is the children who've got bronchiolitis. Those children, usually up to about 1 year of age, but some children leach into the 2nd year of life, have bronchiolitis. It's induced by a virus, and the mechanism of symptoms is in general inflammation. And there's been lots and lots of studies that have looked at bronchiolitis and their treatment of, and the vast majority of these studies show that bronchodilators don't work and steroid therapy doesn't work. At the other end, we've got the children who are slightly older, primary school and above, who have episodic episodes of wheeze, who may be induced by a virus, but they also could be triggered by exercise or smoke or allergies. Those children primarily have bronchospasm, and there's plenty of evidence in the literature to show that they do respond to bronchodilators and they do respond to steroid therapy. And then we're dealing with this mixed group in the middle who have got viruses, they've got some bronchospasm, they've got some inflammation, and they may or may not respond well to bronchodilators. And really, what do we do about steroids? So again, going back to our references of the experts, when you look at what to do about steroids, in children aged between 0 and 5 years, according to the Australian Asthma Handbook, they actually say we should consider the use of oral corticosteroids in wheeze that is associated with the increased work of breathing and is severe enough to require hospital admission. And they also say that they do not recommend the use of steroids initiated by parents in the community. So that's sort of setting the dilemma that we have relating to this management of these children. In 2009, in the New England Journal, there was a paper published by the Panica Group, who did a very large randomised controlled trial studying oral prednisolone in children preschool children with acute viral-induced wheeze. These children, there was over 700 of them, but more than half of them were actually under 2. And the youngest child was 10 months of age. And in this group, they looked at their length of stay and they randomised them to receive either prednisolone or placebo. And their conclusion was that in this group, with mild to moderate wheezing, that oral prednisolone was not superior to placebo. Now, after the publication of this study, there was a real change in direction of whether we should be or shouldn't be using steroids in these children. And the NICE guidelines actually downgraded the use of steroids in this group. And it really made it quite confusing, I think, for everyday physicians who were seeing some of these children who we felt that steroids had in the past made a difference. So we decided to undertake PREVIEW, which is an opportunity to replicate the Panica study, but we wanted to improve it so that we could actually see how usable those results were. So we chose an age group which ruled out children who might have had bronchiolitis. We decided not to just look at the milder cohort. We included children of all severities as long as they weren't hypoxic on presentation. We identified a whole lot of characteristics that might help us decide whether they actually had steroid responsiveness. And we also undertook viral testing at ED presentation so we could determine whether having a virus made any difference to your responsiveness and the type of virus, and did that make any difference. So we included children aged between 24 and 72 months who looked a bit like this, who had a clinical diagnosis of wheeze and obviously profuse coryza. They were randomised to a 3-day course of prednisolone, 1 milligram per kilo, or to a placebo for the 3 days. The placebo was matched to taste, smell and colour to the prednisolone. Our primary outcome was length of stay in hospital, either in the ED or the short stay ward or the inpatient unit, from the time that the study drug was administered until the time they were ready for discharge. And we undertook a number of secondary outcomes. We looked at the baseline severity score and whether that had made any differences. We undertook nasopharyngeal swabs for virus identification. We rang them up 7 days later and found out whether they'd been back to hospital or had a GP reattendance or readmission within 7 days. And we also determined whether there'd been any incidences of vomiting or any other adverse events. Our initial statistical plan was to actually undertake a non-inferiority analysis with a 10% margin in the design, and we based that on an assumption of 45% of our patients would exceed 4 hours in the hospital. And that required us to recruit 304 patients in each group to have the appropriate power from the ready to discharge length of stay. However, before we unblinded the groups, we determined that that non-inferiority was not confirmed, and we did further blinded analysis of our data and demonstrated that one group had superiority over the other. So I'm now going to present the superiority data to you, and the further non-inferiority data is available if you look on the website of the publication. So we recruited 605 patients in total, very even Demographics, average age was 41 months. Of note, approximately 70% of the children had had previous wheeze. Just over a quarter of the children had used steroids for their wheeze in the past, and over 70% had actually had some salbutamol given to them prior to them coming to hospital. This is the money picture. Primary outcome, we demonstrated that the children who had prednisolone had an 170-minute average reduction in length of stay in the hospital, and this was a statistically significant finding. This equated to a 30% reduction in length of stay, and graphically, people often like to see it graphically presented, you can see that this significant change commenced around about 4 hours after the study drug administration. Our median length of stay was actually about 7 hours, and the significant change persisted well and truly past what you would call a fairly long time in hospital, 12 hours. In addition, when we looked at our baseline severity, the children who actually had more severe disease when they came in had a statistically significant reduction in length of stay when they'd received prednisolone. And also, the children who'd had salbutamol before they came into hospital also had a significant difference in their length of stay. No difference with viruses. We were able to demonstrate the presence of a virus in over 2/3 of the children who came in, whether they received placebo or prednisolone, but it didn't matter whether you had a virus or not. Having prednisolone didn't change your length of stay. So what we showed is there was a positive effect from steroids. The median length of stay was nearly 3 hours shorter. There didn't appear to be any significant difference in children who actually could go home in a more timely manner, less than 4 hours. But once you started getting over 6 hours, there was a significant reduction in hospital stay. And looking at it for the longer stay patients, the children who stay over 12 hours, the number needed to treat to prevent one child exceeding 12 hours was 8. So the take-home message, I think, is that oral prednisolone was most efficacious in children who in preschool children over the age of 2 who had viral wheeze with more severe features on presentation, who had limited improvement despite their initial salbutamol therapy, and who also had known previous asthma. And our recommendation really, following the results of this study, is to administer steroids if children are presenting to the emergency department and they're likely to need prolonged ED or hospital care. And what this means is that we actually really have confirmed what the Australian Asthma Handbook has been saying. And if you're interested in reading the full analysis, the paper is published in the Lancet Respiratory Medicine in January, and the appendices with all the full results are available on the online appendix. And I'm happy to take some questions.
Thanks, Meredith. Thanks for that, Meredith. So we might just start with Katie if there's any questions on Twitter.
Thanks, Arj. So Meredith, I've got a question from Casey. He's interested in the selection of primary outcomes in kids' trials, the length of stay versus other patient-oriented outcomes. What's the rationale for the endpoint?
Yeah, we've been asked that a few times about, and it's really difficult to determine, partly because of the group that you're dealing with. Length of stay is a really significant thing for parents. If they're in the hospital less time, then they don't have to reorganise all their other children. They don't have to take more time off work. They can get babysitters to pick children up from school. So people often ask about why length of stay is of significance, but for families it's a very significant length of stay, and it is quite patient orientated.
Significant for the organisation as well?
Well, there's obviously a cost reduction if they stay in hospital less.
And we just had one other cheeky comment. Can we just call everything wheezy bronchitis in the under fives with a sneaky dose of pred for everyone?
I'm still not in the... I still don't think we should be using steroids in bronchiolitis.
So I've got a question from the floor.
Hi, I had a question about the second and third dose of the pred. Given that you found no difference in patients who went to the GP or represented to emergency,
Yes.
are you recommending a second and third dose of prednisolone? Do you feel like that made a difference?
Well, we didn't specifically look at... We just used our normal process, and of course that 3-day course of prednisolone is sort of what's in the handbook. A few people have asked about the use of dexamethasone as a one-off dose, and I think there's certainly some evidence out there now that dexamethasone is equivalent to prednisolone 3 days and a 1-day dose of dexamethasone, and it has the advantage that then you don't have to ask the parents to be giving them a nasty drug on an ongoing basis to a wiggly preschooler. So we didn't look at that, but I think it's got some merit to be thinking about whether we do need to be continuing to do that. If you're going to, once they're going home, then maybe you don't need to continue with steroids.
And just one more question from Twitter. Damien's wondering, do you think that if a 4-hour target barrier had been in place, the results on discharge would have been different?
Well, the 4-hour target was there when we did the study, and we were pretty good at actually achieving our 4-hour targets in that time. That was one of the reasons why we used short stay length of stay as well as just ED length of stay, because we didn't want to be confused with being accused of sort of sending people home without actually giving them the benefit of time of actually proving themselves.
Did you want to come up to the microphone? Oh, yeah.
Thanks, Meredith. I had a question more for the clinical scenario, like 3 or 4-year-olds, say, who are coming in 6, 7, 8 times a year, usually over winter. Now that we have this information, I've had a couple of discussions with parents who have said, well, if it's predominantly about length of stay, sure, we'll do it for the first time or the second time, but is there harm for 7, 8 times a year getting these 3 days of pred? And I don't have a good answer for them. What would you?
I think that demonstrates that those children who are recurrent presenters actually should be on inhaled steroids and maybe it's a winter plan or a year-long plan that they should have until they've actually had the benefit of time to actually outgrow whether they're going to be a true asthma or whether they're going to be just a wheezy child.
Ben would like to know what's the next trial we need to do in preschool wheeze.
I'm a bit burnt by doing that trial, but well, I think the next trial is probably looking at different forms of steroid and maybe the length of time of how much steroids we need to give.
Thanks for your talk. I have a bit of trouble in myself looking at the Panica study and your study. So we've got one that shows giving steroids. They showed a 2-hour reduction in length of stay, and yours shows a 170-minute reduction, and they've concluded that we shouldn't give steroids, and you're saying there should be a benefit. I mean, statistically, I understand, people who understand statistics more than me will be able to show why one's... But as a meaningful thing for a parent or for a clinician deciding whether I'm going to give steroids and what goes along with that, the risks of creating a culture where when you have a wheeze you should give a steroid. I wonder if you could comment on why you think, what the difference is in conclusions between your study and that study.
I think the difference that we had was, as I mentioned, the Panica study, over 350 of their patients were actually under 2 years of age, and we haven't looked at the 2-year-olds. And some people have asked me since we've been talking about the study in our department is, what do I do about this 18-monther? And I go, I don't know. Because we haven't specifically looked at that group, and that group is really murky. It's a murky diagnosis. Is it bronchiolitis? Is this a child who's actually got, a viral wheeze? So that group between 1 and 2 is still a little bit of an unknown. I think the Panica study was actually very close to having very similar study results to ours. And that's why we tried to replicate it, to actually make it, to have the data that you could put together. Your other question was really, what are we going to tell families about whether they should have steroids? I think it's if they're coming into hospital and they're having to spend a lot of time in hospital, coming in either to the short stay unit, staying a period of time, or getting admitted, that I think we can say with confidence that it is helping you. But I think the important thing is that if your child isn't actually that bad, you don't need to be using steroids all the time in the community. And I would be downplaying the use of steroids for children who are well enough to stay in the managed by the GPs at home.
I think you've just answered my question, because I was going to ask about the 18-monther and the 1 to 2 years. So.
Yeah, well, maybe I
Yeah,
should
whether
say
you had
that's
any
the other study that we should be thinking about is
Yeah.
really looking at that group.
So I might just ask the last question, Meredith, about translation to practice. And, we had reference to the Panica study, and that took a while to feed through, and everyone started changing what they did and change guidelines.
Yes.
And I felt like before your study came out, we were at a point where all of that had suddenly been translated into practice, and we weren't using steroids in hospitals for wheezy toddlers. And then your study came out. So what are the implications for standardisation of practice and guidelines of your study in light of the time for knowledge translation and what's happened before with the Panica study?
Yeah, I think there is opportunities for knowledge translation, which is obviously something that we should be doing. There is another study that's been completed in New Zealand. Stuart possibly is here in the audience. I think there is an opportunity for us to do a nice meta-analysis of data and actually start putting that together to actually influence, and I think we need to do a whole guideline around that and influence the asthma handbook further.
All right, thanks, Meredith. That was a great update on steroids in wheeze.